Okay, so this is the part that we hope that you all would participate. This is to ask any questions for the speakers who have just spoken.
Dr. Chen, can I ask the first question?
Of course.
Okay.
Chairman's privilege.
Okay, thank you. May I ask Professor Lee, very interesting talk about unproven therapy. Now, in Korea, can you give us some examples of unproven therapies that have gone through the evaluation of your committee and now is being used in patient? Thank you. Any examples?
Currently, we have a system to evaluate the unproven therapy, even though it is not undergo the scrutiny of the quite strict FDA process. We call it an innovative treatment pathway, or it is under the auspice of national insurance scheme, because we try to cover the possible, and also it lessen or it lowers the barrier to engage in this process. So there are several projects. So it is quite related to very scientific in its nature, not to something called very the alternative or some other issues. And also what we have, I want to add is in Korea, we have a separate healthcare system. It is one thing is the orthodox medicine and other is Oriental Korean traditional medicine. So these are separately regulated. So in orthodox medicine's perspective, it is alternative or it is unproven. But from the Oriental medicine's perspective, oh, it is okay. It is proven. So there is always some kind of disagreement or concern or conflict in these two fields. So, but I'm sorry that I don't remember any concrete issues about that.
Yes, please.
Okay. Thanks. Yeah, Owen again from CBME. A wonderful set of 4 different talks. I wanted to focus on an underlying thread that was in a few of the talks, which is about the intersection between sort of innovative care or novel care and research, right? And this fine line. A couple people, for example, mentioned MURI, which is meant to be a sort of way of providing unproven treatments outside of the research paradigm. But what I've seen from a lot of these approaches, and especially after the COVID-19 pandemic, is that ultimately, when you have enough resources, when you have enough attention, it is feasible to put a lot of these innovations under a research study, even if it's only observational or a pilot study of some sort. And increasingly, we're looking at the idea of a learning healthcare system, which integrates more and more regular care, including innovative care, into a research paradigm. But there are, of course, challenges in trying to put more and more interventions systematically under research. But then the kind of advantages being you could reap that generalizable knowledge to improve care going forward. So just let's get thoughts on threading that needle between trying to put more of these novel treatments under research versus if people think that that's what we should be pushing for, or whether it's acceptable to carve out some things outside of the research paradigm as a matter of practice or pragmatics. Over.
Yeah, thank you for that question. I think it's a very important question, and I think COVID was an outlier. And there was no time for doing research, and we had to use whatever worked. And people tried everything from hydroxychloroquine to azithromycin to all kinds of things. So I think the authorization for that was on an emergency basis. And if you look at the Indian government's approach there was an emergency use authorization for 2 vaccines, though trials are not done. One was the Oxford vaccine, or Covishield, which is in India called Covishield, and the other is an indigenously made whole cell or rather whole virus vaccine called the Covaxin. The issue was the government decided to use it because there was some data, very rudimentary data, which showed that it produced adequate immune response but not protection. So the issue was, it was an emergency and it was used temporarily. I'm sure under normal circumstances, MURI will not be applicable. And coming to the other comment which Professor Lee mentioned was regarding which of the drugs started as a drug which was used on an experimental basis and now is in clinical practice. I can think of sildenafil. Sildenafil was used for pulmonary hypertension as an experimental drug because it showed a very good response. But subsequently now it is in the standard of care for the management of pulmonary hypertension.
I wonder whether, Owen, you were thinking about, instead of clinical ethics and clinical care, you have something in between, that you can do research, but not quite full research, but it's not quite full clinical care, but something in between for emergencies. Is that what you mean?
Maybe. I'll get opinions on that. There is a thing.
Like an accelerated research kind of realm. Other questions? Yes.
Hi, I'm Sarah, a pediatrician from India. My question is to Dr. Jonathan. So, do you have any data on mothers who did not give consent for the fetal intervention? And if so, any analysis on whether it's a maternal decision, paternal decision, or the extended family's decision?
So, no, I don't have any experience over here with respect to decisions as to, who made the decision. I had a brief conversation with the group starting this program in Boston, and they would engage the family. The mother is a primary decision maker. And in the early start, whilst they were putting this program together, they made it such that they would not do the procedure if there's fetal aortic valvuloplasty, if the decision by the family was to keep the pregnancy should the procedure be successful, and not keep the pregnancy should the procedure not be successful. So they wanted to remove that out of the equation. So therefore, that meant that the procedural success would not would not be related to the parental choice. That's one, perspective of things. As far as that discussion went as well, I also understand that there was no instance in which the fathers had refused maternal consent. That means when the mothers made a decision to go ahead with the procedure, the fathers did not say no. And as that conversation went as well, I think it was very far between that, having seen the evidence, the mothers did not make a positive decision for the procedure.
I think.
Hi, thank you for those wonderful speeches. My question is for Ihak. So regarding this unproven treatment, I think the challenge will be that it is not really going through for the clinical trial procedures. But at the same time, people are demanding this. They think they have the right to try. They want to have hope, even using compassionate use. But in terms of pediatric ethics, okay, the general idea is that we should avoid using vulnerable subjects for research unless you have a strong reason to do that. So the standard practice is that you should use the normal population. Then when you need to really research on this vulnerable subject, you need to prove to the IRB that you have the right reason to do so. But then we think this attitude has been changed because that will doing the overprotection and making this vulnerable subject even more vulnerable. So the argument will be the other way around. If you don't have a good reason to stop the vulnerable subject to enter the research, you should put them on this trial. But if you push it forward to the unproven treatment, it will be more complicated because you will lack this standard review process to safeguard the participant, their interests, and how to protect them, how to do lots of rectification or rescue for them. So the challenge will go back to, okay, whether can we have a good process in approval, okay, for this kind of compassionate use or unproven treatment, because it cannot go through the traditional IRB, but it cannot be seen as the regular treatment. So I wonder if in your Korean expert committee discussion, have you created a good solution for this kind of something in between? Okay, just like, okay, Mayo has mentioned that. Okay.
Very difficult, and also I'm frustrated that I'm here to learn from you. And we are trying to narrow the gap between research and practice, and also there is some schemes for, especially for stem cells or some regenerative medicine, we have some very rapid track to apply it. But meanwhile, it means that there happen to be a bad guy in the field who exploit those patients or parents, saying that we have this treatment, we have this result, only in cases 1 or 2. I'm not sure with the proper review. But anyway, so we need to protect parents and patients. And also we need, as you mentioned, we have to open the chair. So in my opinion, if we can, this is something we have to do by case approach. That if this is happen, not the general idea is all, I think it is already well established. But as for the individual case, we need some institutional approach to review this. But it is not some kind of some systematical, well established. Only in ideas, or only a review between the professionals or within the departments, or some kind of the clinical practice review committee of but what problematic about this is when it goes down to the nursing hospitals or other healthcare providers less regulated by the well-established system. So they are whatever name we can find, that hospitals that provide that kind of the unproven treatments. So it is the place we have to protect parents and the patients. So I'm not sure that I have provided you the proper answers to this.
Thank you. Dominic?
My question is to Dr. Hasworth, though I wanted to raise a common thread. So what I wanted to raise was how you thought about a particular so-called ethical rule, but I don't think it's a rule. It's the rule of rescue. The rule of rescue is the urge to rescue the identifiable patient in front of you, and often associated with use of vast amounts of resources to do so. But it comes at a cost, and the cost is the unseen patients who don't get treatment, but who you don't see. So I wondered how you thought about, because it strikes me the strongest concern about giving advanced medical care in the communities that you describe is that you could potentially save more lives by using those same resources, the same donor resources, on vaccines, antibiotic delivery, basic sanitation, compared to the lives that you save by doing something very visible, very striking, very emotive, saving 1 or 2 children from snake bite.
Great. And indeed, I used the snake bite example as an exciting point. The answer to your question, and certainly in rural Cambodia today, is that all those other things, vaccine coverage, public health measures, these things have been worked on in Cambodia for 20 years, 30 years. Other people are doing those things. We show up and we look around and we say, what's the real problem here? What's not being addressed? And part of the answer to your question is my mindset. I'm in the United States, I'm an emergency room doctor, and we face that same problem in the emergency room. We have bells and whistles that tell us to respond to a stroke patient way beyond the bells and whistles tell us to respond to the elderly pneumonia patient sitting in the waiting room. And so my mindset in life, both in the ER in the States and in Cambodia, is to look for those unseen patients and try to constantly weigh the benefit of who it is you can save and also get to the unseen patients. And I don't know if there's an exact formula for doing this in healthcare. It's a mess, whether it's in the United States in the ER or in Cambodia. But I personally, and I think our team as well, are looking for the unseen. And we do it in Cambodia by reaching out to the villages. We do it by radio advertisements. We do it by advertising and trying to get people in to see us. We do it, Professor Roy gives a lecture while he's in Cambodia, and we make sure that every health center comes and hears his lecture so that they know what our resources are. We try to make it equitable, But at the end of the day, it's a bit of a scrum.
I think I cut off, Daniel, you wanted to say something just now?
Just a brief response to So I wonder, okay, because I was facing the same challenge and commissioned by the government to see if we can explore some way of reviewing that. So there's one proposal saying that because this is more like a clinical practice, but you still need some oversight body to do that. So why not we use the clinical ethics committee helping review rather than using the research ethics committee, okay? Because that part is quite rigorous. You must abide by the law and every SOP details to be correct. But in the clinical ethics review, you will emphasize different rules, more like desperation, urgency, and the eagerness to survive or other things. So probably that could be a way of thinking. Just like to hear about your comment. Thank you.
Thank you. I don't have anything to add.
Actually, we face the same thing in Singapore as well. We have all these innovative therapies that are going through the clinical ethics committee. But I think the problem with the clinical ethics committee is these are not necessarily domain experts. And so it's hard to sort of assess based on the science. And we have to sort of trust the clinicians that it is really something that is worth doing. I think in Singapore also, we also kind of have a in-between. There's talk about having this realm called the sandbox realm where patients don't qualify for the research because of whatever criteria they didn't qualify. But on the other hand, the physicians don't really want to waste time to refer to the clinical ethics committee that goes through all the realm about compassionate use and all that. And so they want to have like a sandbox that is an in-between. But I think we have to be really careful that it's not used as a loophole to escape the rigor of research committees and escape the problems of going through the ethics committee. So I think Aishwarya has a question.
Hi, good morning. I'm Aishwarya. I'm a pediatrician from INUH. This is to Dr. Will. So I was just wondering, thank you for sharing about Chenla Healthcare and the multiple ethical dilemmas that you face. So in terms of provision of sustainable care, let's say you set up advanced medical provisions, an ICU in a setting, does that then provide a moral obligation to continue that? How do you deal with, if you run out of funding or if you have to stop provision of those services?
So far, so good. We haven't run out of funding. And we actually have a more holistic approach than I conveyed there. I think that, again, the biggest ethical dilemma for Chenla is, okay, we're going to do this level of care. That's a bit crazy. But we start with an outpatient clinic, an inpatient ward, and we have, over time, we have specialists. We have cardiologists and people who have been trained in various specialties working with us, both on a full-time and part-time basis. We're trying to provide the holistic care. This is a question for, ideally, we're an NGO. The idea of an NGO is for us to get kicked out of the country and for the government to do it. So our model of success is for me to be asked to leave. But we do have a huge obligation to meet needs in a fair and equitable way. And what's the moral obligation to the snakebite patient who's dying in front of you? What's the moral obligation to the patient who has chronic heart disease that needs a diagnosis and a fix? And I'll be honest with you, I don't have an answer to that. I think that our Cambodian team is very good at assessing the patients, looking at the resources around them, and honestly, they're kind of cheap. So basically, if someone else can provide the service and we can get that patient to that place that has that service, we'll send them there. That's much more efficient sometimes than us providing services that others somewhere else in the country is already providing. These, again, are the most remote provinces, so this is a 10 or 15-year project before more holistic services through the government are probably available.
Ross?
Hi, I'm Ros McDougall from the University of Melbourne, Australia. My question is also for Dr. Houseworth. Thank you all for your great talks. One of the things that I do in my role is teach ethics to students in the Master of Public Health program at our uni, many of whom aspire to work internationally. And one of the worries they have is coming in as outsiders with a particular set of values into a different kind of context. So I'd be really interested to hear your reflections as someone who's clearly very successfully navigated coming in as an outsider and providing healthcare in a different context. How you've found the congruence or incongruence of your values and your staff's values with the values of your local partners and the families that you work with.
One of the best pieces of advice I got from a professor at Harvard before we went out and did this stuff, he said, Bill and Lori, you guys should go sit somewhere where the needs are and do nothing for at least 1 year. And we basically did that. I took the job at Anger Hospital for Children in 2008. I didn't change anything. I didn't do anything. I just sat and listened and tried to understand the context around me. And then that formulates all sorts of questions in my mind, and I think in Lori's mind as well. Okay, these are things I feel like I'm right about. Maybe I'm not. And maybe there's a completely different way of handling this in the context here. But then how do I not give up my values and not go insane trying to work in this context? And it's been a balance. It's balanced for 14 years of doing this full time. And I don't know if that really specifically answers your question, but the biggest advice I think I received as a student was go where you want to work and sit for a year and do nothing, and then you'll have a better chance of success.
Thank you.
Yes, Dominic.
Jonathan, I had two tricky questions for you, so forgive me. So one was fetal intervention for critical aortic stenosis preventing hyperplastic left heart phenotype. Looks like a kind of icing on the cake, really small, kind of highly developed countries, very small number of centers. But presumably across the region, there are lots of places where surgery for hyperplastic left heart, transplantation, kind of, is just not an option. So the alternative for these infants and fetuses is that they die. They either are terminated or they die in the newborn period. So is there an argument actually that this ought to be in a kind of medium resource setting, much more thought about as an attractive alternative? And then I've got a different question which is harder, but I'll
Okay, so let's go with that first question first. Now, difficult question, obviously. I think it's important to remember that it takes a multidisciplinary approach to care for, the child with a heart condition in the fetal stage, as well as a neonatal stage, and in the childhood, context. Now, I guess it's going to be difficult, to put together, what are the resources required, to do something in the pediatric age group versus in the fetal age group. I would argue that it would be, a broader approach, a more rigorous approach, perhaps an approach where there would be, multiple options available if we aim to do a procedure in the pediatric age group. And it gives us, opportunity as well to build the program from there. From the perspective of pediatric cardiology rather than fetal cardiology. So I would argue that it would be a lot better, perhaps cost-effective, perhaps even from the governance perspective, to have a well-developed pediatric cardiac unit versus a fetal cardiac unit with fetal intervention. So I'm going to flip this around. As I mentioned during the talk, if I do the fetal procedure and there is aortic regurgitation, for example, for the pediatricians in the room, will I be able to handle that complication or not? And if I do not have a well-developed enough pediatric or neonatal procedural program, either intervention or surgery, then it would be much, much to the detriment of that, baby, if we do something in a fetal life, for example. I hope that, you know...
So just to respond to that, it's going to depend on the alternative, because if the alternative is that child has hypoplastic left heart which is untreatable, it's going to be better for that child potentially to have difficult aortic regurgitation that they can't access the surgery than to die in the newborn period of hypoplastic left heart.
So that's another value judgment and another value question. So I think it's going to take a while to answer that question. In providing alternatives, in my view, I think it would be better to provide an alternative in a pediatric age group and a neonatal age group. And the argument for this is, as mentioned, I think it allows further progress and further development in pediatric cardiac surgery and cardiac intervention. And if this is the gap in this region, then it would be better to have a broader perspective, broader options, more alternatives at that age group. It would also be easier to implement, because in pediatrics we realize that many of the interventions and procedures that we do come from the adult age group. So we are bringing adult procedures to the pediatric age group, and perhaps as an argument we bring the pediatric procedures into the fetal age group. And therefore, I think in the way that we develop procedures as well, and interventions and options, it would be, more feasible to do so by developing a pediatric cardiac program.
So it's kind of society over individual, right? You want to advance cardiac surgery or cardiac intervention over the interests of that particular patient?
I mean, in a certain way, yes. I mean, as a pediatric and fetal cardiologist, I mean, I would, want to advocate for fetal cardiac, interventions actually. Because it's a 2B indication, it is a level evidence, B. I think it's reasonable to do so. But I think we need to think about the broader perspective. And if I have to put, this answer back into that framework of why I gave the talk in the first place, the question of, should I bring such cases up to the CEC, Clinical Ethics Committee? And my answer would be yes. The reasons why would be to reduce the likelihood of conflict of interest, to make sure that the procedures, are well solidified, the governance structure is, well established, and I think these are the reasons why I put up to the CEC, and we can set a time to that, program, and following a 2-year program or 3-year program, review the data, go back to the CEC, and then discuss on whether this needs to, be continued or not, and that would be my perspective of how to get things going.
I have another question, but I don't want to monopolize because I can see Vijay's got one.
Hi, I'm Vijay, a neonatologist here in Singapore, and I had a couple of questions for Professor Brian Chun.
It shouldn't be the session, but if Chairman allows.
Anyway, I will ask a very long question, so you have a very short time to reply. My question was about genetic screening, and as you showed in the first couple of slides, a vast majority of these results come back of unknown significance. How do you counsel families when you get a result like that? And the second question is, should an unexpected result turn up, what implications are there for families in terms of, for example, insurance? Do they have to declare that?
Let me answer you in the context of the Hong Kong Genome Project, because as a practicing clinical geneticist, this is a problem, a variant of unknown significance is a problem that we would have to deal with every day as well. So within the Hong Kong Genome Project, we will issue a research report for our patients, say in the fields of undiagnosed disease. So the way that we handled it is we got an endorsement of our approach in the Scientific Advisory Committee. And the endorsement is as followed. We only report disease-causing mutation to the families. So that would, if you use the American College of Medical Genetics and Genomics criteria, only those pathogenic and likely pathogenic mutation would be reported. There is one exception. The exception that we will also report VUS is, first of all, this VUS has a post-test probability that if with one additional criteria, it could be upgraded to likely disease causing. And the way that could result in such upgrading is something that we think is clinically doable, including inviting additional family members into family testing to look at the gene or the mutation segregation, or an additional investigations that is available in the hospital that increase the specificity of the clinical phenotype that would be matching. Then an interim report would be issued after discussion in a multidisciplinary team meeting, so that the clinician can use that research report to explain to the family what is happening, and through that perhaps ask for the permission of agreeing to bring in more family members or to do an additional MRI brain in the hospital. And that's for that purpose. And when additional family members come for the genetic testing, or when an MRI is available, then we all make the judgment whether these new information can help to upgrade the variant of a known significant. So ultimately in the final report, so to say, it would only be positive or negative, no VUS. So the way that we handle VUS is exactly the reason why we start the project in the first place. We would like to accumulate enough genomic data, but not only the genomic data, but also the clinical information to establish a clinical genome database for Hong Kong. And we think that only in this way that data that is collected would be most reflective of the local population. And through that exercise, hopefully, the variant that we see as VUS would decrease. Just to act in this additional information, in our group, we have actually done a meta-analysis looking into all published papers on exome and genome sequencing. What we're interested to see, for the sake of the project, is exome sequencing, genome sequencing. The VUS detection rate is very similar. There is no statistically significant difference. That's why it gives us more confidence that perhaps genome sequencing is not causing more harm in this way. And when we look into the detection rate of VUS, according to the year of publication of these studies, we see a dropping trend. So that also showed us the more we're doing it, the more we're looking into it, perhaps it will give us more information. And of course, this could only be possible if we're working on our own population, we're sharing our data so that we know what variants are not harmful and what variants could cause a disease in the longer run.
And the second part was the implication for, let's say, insurance.
Thank you very much. I forget about this question. I think for this, the Hong Kong government has done a good job. It's because before the starting of the Hong Kong Genome Project, the Health Bureau of the Hong Kong government actually talks to the federations of insurers in Hong Kong. And they have reached an agreement that this, as well as the Hong Kong Genome Project, as well as other research projects, these are information that the insurers shouldn't ask for when there is a person coming in to ask for a medical insurance coverage. And we make sure that our participant knows about this. So it's a research project, just like other research projects. The insurers should not ask for this information. Sorry, I take up your time.
Do you want to ask your question?
Let's go back to this session.
So Jonathan, I warned you I was going to ask another tricky question. So one of the things about fetal interventions, a bit like some neonatal decisions, is that they take pediatricians out of their comfort zone in terms of pediatric ethics and into the area of obstetric ethics and termination of pregnancy, which makes some pediatricians deeply uncomfortable. So I'm just going to, I may have misunderstood. I think you said that the proposal was that mothers wouldn't be offered this intervention if they would terminate if the intervention was not successful. Is that right? And what's the justification for that?
So there are two things about that. They just wanted to remove that the decision to terminate a pregnancy, away from the decision to do the procedure. That's just as a start from their perspective of starting a program. Now, the other thing is a practical issue. If you remember the case I showed you, the aortic stenosis usually presents at about 20 to 22 weeks. I mean, that's obstetric screening. But the procedure is usually performed around about 25 to 28 weeks, where it becomes clear that the ventricle then becomes dilated. And so by then, in many senses, it would have already been beyond that, period of termination of pregnancy. So one was actually from perhaps a perspective of they just wanted to be clear with respect to their, their research position, and the other was a practical position, a practical reason.
I think we have time for one more last question.
Thank you, panelists, for your informative talks. My name is Joel Wong, pediatric surgeon in private practice. It's just when we have improvements and these interventions, how have we been engaging with the insurance companies? Because more and more often, the insurance companies are excluding congenital conditions, and sometimes they can be quite sneaky about it. So there's a small clause, fine print, that says congenital conditions are not included in terms of the costing and the payment for it. So maybe I'll rephrase my question is when you appeal to the people in power or influence to lobby for this inclusion of congenital conditions, because everything else will not be paid if this condition is still in the insurance policies. What's your opinion about this?
I'm not so sure that we are people in power, actually.
This is APEC, surely.
I mean, I think I'm not in power, okay, but I'm trying to think what the position is in Singapore, right? Now, I think there is a possibility of funding for congenital heart or even like congenital defects with MediSafe and MediFund currently. That's the first thing. The second thing is that many insurance companies in Singapore, they actually have a pregnancy sort of like insurance, and they insure for particular catastrophic fetal, anomalies and congenital anomalies within a period of time, like 1 to 2 years. And then within this period of time, then you can claim if, for example, there's a procedure that is required for the neonate subsequently. I'm not sure whether anyone else in the room has any other experience with this in Singapore and other countries.
Actually, I wonder though, I mean, you are talking about congenital as in the child is born with something versus inheritable, which is something that the child inherits. So like, for example, what John was talking about, aortic stenosis, if you actually fixed the aortic stenosis before birth, technically the child doesn't have a congenital condition. But then if something else happens that is related to the heart, I don't know, maybe they didn't fix it properly and it becomes regurgitation, right? Then does it cover though?
It'll always be congenital. So the point about aortic stenosis is that we cannot give in fetal aortic stenosis, we cannot give the child a normal aortic valve, right? I mean that's fundamental. And as the child grows, you expect the child would potentially A, have worsening stenosis, B, developing regurgitation, and even aortic root dilatation. And so from that perspective, I think we can't say that we've cured the child, number one. And number two, they would still have residual cardiac defect at birth, present at birth, if we want to be really truthful about the word congenitus.
Because for the insurance companies, a lot of time when we say that it's congenital, means it's before birth or happen at birth. So that is exclusion criteria already for some of them. So they're not so smart to understand the intricacies of this condition.
Anybody else has any experience over this? Maybe we should really engage the real APEC and not this APEC. Okay. Otherwise, I think it's 12:30 and it's time for lunch. Thank you very much for this spirited discussion in the symposium. I hope this is going to continue over the rest of the day. Thank you.